Thank you for the invitation. I'm Dr. Joanna Contreras, Director of Laboratory Heart Failure at Mount Sinai, and thank you for inviting me to this amazing symposium and lectures. So I'm here to talk about the heart failure management, and I'm gonna really focus on mostly symptomatic heart failure and mostly heart failure with reduced ejection fraction. As you know, there is an expanding epidemic for heart failure. We know that about 5.7 million of Americans are living with heart failure, and we know that the projections are going to increase about 46% by year 2030. So we're going to have more than 8 million cases for heart failure. The incidence continues to increase. I think this is an old, but with about a million patients of new cases per year, and we know that there is more than 1 million of the primary diagnosis of patients hospitalized for any reason, and more than 3 million if you actually use heart failure as a secondary diagnosis. What that means is going to be a very costly disease for our health system coming up. And as you know, CMS are actually putting a lot of criteria about how to reduce hospitalization for heart failure, because not only because of this, obviously the cost and the burden of hospitalization, but also the mortality and the reality that one patient gets admitted for heart failure, there is a significant increase in mortality up to 30%, and that we know that independent of the ejection fraction, so independent if you have a reduced ejection fraction or percent ejection fraction on mid-range, the mortality is the same. If you get readmitted, the cardiovascular mortality is similar, only a little higher for heart failure with reduced ejection fraction, but it's definitely similar, independent of cardiovascular admission, any cause of admission, or for heart failure. That is, with CMS are penalizing hospitals if you actually have no ways to reduce hospitalization for heart failure. Another that is very important is if you look at this data, of these patients admitted for heart failure, within 5 years, 75% of patients hospitalized for heart failure will be dead, regardless of ejection fraction, which is making this disease a lethal disease. Even if you look at cancer, if you combine all the most common forms of cancer, lung cancer, breast cancer, prostate cancer, and colorectal cancer, the mortality for heart failure is higher than with most of the cancers. So it really this is to make us worry when we actually see a patient with heart failure. And as I'm going to show you later, it's very important that we actually optimize treatment for this patient as soon as possible. When you want to contextualize the risk of worsening heart failure. So when you have a patient in the hospital with acute heart failure, or in your office, or you see in the ER, we always think about patients with the coronary artery disease, or the risk of that patient to have an acute cardiovascular event. And we know that those patients, we calculate the risk is high, is intermediate, or low, and that's how we intensify the treatment and the prevention of the statins and the aspirin and everything else. When you actually look at heart failure, you actually are studying those patients with a risk factor of 10%. And it's definitely about that 10% that you're actually seeing a patient for heart failure. So every patient for heart failure that you're seeing is already at 10% risk of having an adverse cardiovascular event. So that's this to see how important it is for us to really intervene and really treat these patients. For many years, heart failure was a concept that we have some sort of preload, increase in preload, decrease contractility, increase in afterload. And we did tons of clinical trials in the 1990s. We talk about we had to decrease preload with diuretics, we had to increase contractility with digitalis or inotropes, and we had to decrease afterload. We had a HEAT registry that showed that diuretics had no mortality benefit. Do we have to use it? Yes, but it's no mortality benefit, but we have to use it. This trial showed no mortality benefit, so that failed. When we look at the inotropes trials, there was really no mortality benefit, even a slightly increasing complications. And when you do look at the afterload reduction with the VHAV and AHAV, there's a lot of mixed results. And why? Is because we were only looking at the ice at the top of the iceberg. When we actually look under what is happening with the person with heart failure, is a multi-system organ disease that has inflammation, fibrosis, metabolic alterations, calcium regulations, alteration in the natriuretic peptide system, and neurohormonal activation. We know that neurohormonal activation, we understand that well, and we're going to talk about that. We also know about the alteration in the natriuretic peptide system and metabolic alteration with the glucose metabolism. So the neurohormonal model that we have been using for many years We know that there is some injury to the myocardium, even you call it acute infarct, chronic uncontrolled hypertension, myocarditis, and that produces left ventricular dysfunction. We do know that that creates activation of the RAS, the sympathetic adrenergic system, the MP system, and the aldosterone. That creates peripheral vasoconstriction, hemodynamic alterations that obviously early on will help the patient acutely, but when that becomes a chronic cycle, you have remodeling, worsening nerve dysfunction, you have heart failure symptoms. And that's how you increase the myocardial toxicity and the morbidity and mortality increase. We know that we can block the sympathetic nervous system activation using beta blocker. We have been using beta blocker for many years. We know the medications work and it's having our mainstay treatment for patients with heart failure. Multiple trials that I don't want to review because there are probably, I'm going to mention them, but we don't have to review all those because we had that data. We know that RAS inhibitors, called ACE inhibitors, ARB, and MRAs, that are aldosterone inhibitor, are very important because they block the activation of the renin aldosterone system. And we now know that it's very key to be able to improve symptoms in persons with heart failure. But now we know that also there are endogenous we have endogenous compensatory peptides, como son del NP and the bradykinin and the neprilysin inhibitors that is important in the system. So we know that we have a new medication that is Entresto, that is RNA, because Entresto is a combination of two, it's a combination of valsartan, that is a angiotensin 2 inhibitor, and it's a combination of neprilysin inhibitor. Why? Neprilysin is an enzyme that is in charge of destroy the BMP. So when the heart gets distended and overloaded, you secrete BMP. The problem with BMP is that neprilysin degrades BMP very fast. So for many years, we tried to block the mechanism. We did for the people that are older in the room, we did a lot of natric core infusions. We did a lot of things to be able to block the mechanism. What we realized is the life of this medication is very short. So we realized that also neprilysin degrades angiotensin 2 blockers. So if we don't block angiotensin 2, then we're gonna, only block neprilysin, we're gonna have increasing angiotensin 2. So Entresto really the combination of neprilysin inhibition and valsartan to block the angiotensin 2 receptor. And that's the reason why Entresto is the enhancement. It has to be the combination, really the one that works in heart failure. So basically giving the patient valsartan plus a neprilysin inhibitor. What happens is you block the action of angiotensin 2 and you block the degradation of BMP. That's very clear. So we know that neurohormonal activation is very important. And we also now know that the cardiometabolic glucose obesity is very important. And this hypothesis, obviously, in the next few years, if you have seen multiple trials and shown the importance of the SGLT2 and GLT1 blockage. And we're going to talk about that later. So now, as Milton Packard said, heart failure is a systemic illness and not just merely a cardiac illness. So we describe heart failure is more than just a failing muscle or pump. It's an imbalance of hemodynamic and neurohormonal compensatory mechanisms that keep homeostasis due to the maladaptive response. So that's very important concept for heart failure, and I want to remember that. With the novel definition of heart failure, we want to focus in how you define heart failure, because heart failure is more like a syndrome. Now we know that heart failure is the patient has signs and symptoms of heart failure that are caused by a structural or functional cardiac abnormality, valvular dysfunction, LPS, and myocardial infarction, and signs and symptoms and structural or functional cardiac abnormality, and at least one of the following. You have elevated MPs, so you know now I put the range there, elevated BMP more than 335, and in hospitalized patient more than 100. Or an NT-proBNP, that is the preliminary to BNP, more than 125, and in hospitalized patient more than 300, okay? Or you have objective evidence of cardiogenic or pulmonary or systemic congestion, okay? That definition plus left ventricular ejection fraction assessment. So if you have the signs and symptoms of the structural abnormality plus either the BMP or the objective evidence of congestion, then you look at the ejection fraction. So you see the patient have heart failure with low ejection fraction, heart failure with mild reduced ejection fraction, heart failure with for set ejection fraction. You can turn it mid-range, improve ejection fraction, or supernormal ejection fraction. Some labs have read ejection fraction as too high. You have to discard that the patient doesn't have a hyperdynamic ventricle. Very important to know that. Signs and symptoms of heart failure. Typical symptoms: orthopnea, breathless, paroxysmal nocturnal dyspnea, exercise intolerance, fatigue. Less typical, people that have nocturnal cough, that are wheezing, that are bloated, because sometimes the right side failure can cause bloated, decreased appetite, dizziness, syncope, depression, cognitive decline. More specific, overly the signs: elevated JVD, their heart sound, the summation gallop, the cardiomegaly, hepatojugular reflex, Shenstone respirations. Less specific, peripheral edema, make sure that it's because of that, pulmonary rales, unintentional weight gain, rapidly, especially person can like 4 or 5 pounds in one day. In advanced heart failure, ovary cachexia, cardiac murmur, tachycardia, tachypnea, hepatomegaly too. Cold extremely, you have hypoperfusion, oliguria, or narrow pulse pressure. Also remember there are other causes of elevated NT or BNP, no? Sabemos que pulmonary embolism, myocarditis, cardio-oncology, we use BNP to follow the symptoms, pericardial disease. All these things can cause the person to have elevated BNP. So that's very important. All the other causes, kidney disease, people with dialysis will have chronic higher BNP levels, severe anemia, or person with thyrotoxicosis or liver disease, pulmonary disease, important to remember that, and lower levels of BNP, obesity. So people that are very obese, sometimes with very big BMI, a lot of peripheral fat, they can have lower levels of BNP even though they can have heart failure. So that's very important. Classification of heart failure, this is new. So it's heart failure with reduced ejection fraction. The point is 40. Less and equal to 40, we're talking about reduced ejection fraction. What happens? You can get treatment for that and get better, so you can improve that, and you can become every year more than 40. To improve ejection fraction, you have mid-range between 41 and 49. So in between 40 and 50, we are including 40 and 50. And you can have heart failure with preset ejection fraction that can be an ejection fraction equal to more than 50. Very important because the guidelines try to determine that. The stage of heart failure. So once you decide when the person has heart failure, now we know what the ejection fraction is, reduced or preserved. We have the patient in different stages. Stage A is the person at risk of heart failure. I will say any person that you see in a cardiology clinic is a patient on a stage A heart failure. And sometimes for my fellows and my students, I make sure that they put that on the note, because then you have to start thinking, what do I have to do to prevent that person is gonna go into stage B heart failure? So that's important. Any person with risk factor, hypertension, chronic kidney disease, obesity, cardio-oncology patient, anything like that is a stage A. A stage B is a patient with structural abnormality. So it's a patient that don't have signs and symptoms, but they have LVH, they have a valvular disease, they have something that causes an structural abnormality. Stage C, that is the patient symptomatic with heart failure. And that's the patient that they fulfill the description of structural and functional abnormality and has symptoms. Why did they go with the patient? We want to get that patient on remission. Remember, like cancer, we want that person to go on remission as soon as possible. With GDMT, we have the therapy that can help, or with the person that goes on remission is the person that going to have persistent heart failure. And then you're going to go to the advanced heart failure person that we're going to talk about it. That is the person that despite GDMT, despite maximum medical treatment, still symptomatic. Then we have to start thinking, what else can we offer that patient, and when do we have to refer that person for advanced heart failure therapy? I want to make a point here for women. We forget there is always traditional risk factor for heart failure and for cardiovascular disease, hypertension, diabetes, smoking, obesity, inactivity. But I want to remember for women, we have a significant literature now looking at gender difference, and we know that we need to remember, one, women have pregnancies, and pregnancy is a window of the woman to the health system many times, and a window to see how she can react to stress. So very important in women to take the history of pregnancy, any history of hypertension, diabetes, or any issues during pregnancy are important risk factors for women. More likely to have ischemic heart disease, 3 times more likely, and more likely to have heart failure. Autoimmune disease, very important for women. A lot of lupus, a lot of rheumatoid arthritis, and those diseases, very frequently we end with heart failure with prostate ejection fraction. Menopause, early menopause. A lot of women that have cancer early, they may have an oophorectomy, they may have an early menopause in a lot of treatment that they have with cancer. So it's very important to remember that, or obviously people that have early menopause for other reasons, especially now that we have a lot of in vitro fertilization that cause women to get into early menopause. So it's very important that we actually talk about that, and important for the person because we know it's important risk factor for both men and women, but very significant risk factor for women to have heart disease. And then you go to the profile. It's important to classify what can my patient do. If my patient can do everything, work, go to the exercise and everything, so it's class 1, New York Heart Association class 1. I know there's a lot of controversy about this classification, but honestly, it's something that we have for many years. What patient have mild symptoms is class 2. What patient have moderate symptoms is class 3. Very important because we can treat this patient very, very early and improve that. And severe symptoms over class 4. We do know that also heart failure progresses over time. So we know that the patient have the initial baseline heart failure risk. We can to treat them. We do everything we can. And we can keep that patient with controlled heart failure for many months or years, but eventually the person is going to have worsening heart failure, and we need to see what can we do to improve his heart failure. And that worsening heart failure, it's very important that we determine why and how can we improve it. And obviously the patient going to advanced heart failure, can we offer anything to this patient? Can we refer the person for transplant, palliative care, or mechanical support? Oral medication we have the super medication. We have the beta blockers that have been for a long time. We're gonna have the ARNI now, the Entresto, the AGL2 inhibitors, and the MRAs are the base of this patient therapy. We know we have new kids on the block. We have verosiguat, sotagliflozin, and I'm gonna mention a little bit about mercaptan. So I'm not gonna review the beta blocker diet because you probably are gonna talk about that, but if we go back to the trial with ACE inhibitors and IRBs, the RE-SAVE SOL trial and the consensus, they all were many years ago trial that really show the significant mortality benefit in patients with heart failure when they are treated with this medication. But now we know that really Entresto have overstated this because of the potent neprilysin inhibition. We also know that beta blockers, we had the Capricorn trial that was post-MI, the MERIT and the US carvedilol that is using in mild to moderate heart failure, carvedilol and metoprolol, succinate that shows significant mortality benefit up to 26 and 30% decrease mortality, and Copernicus in severe heart failure that show with carvedilol significant decrease mortality. We know that the MRAs, eplerenone and spironolactone, we don't have a lot of trials on that one, but we know that Rails really put spironolactone on the market for severe heart failure, and eplerenone with ephesus and emphasis for heart failure with reduced ejection fraction. So that's very important, and that has been the mainstay therapy for heart failure. Important to mention, it's important to pick up the beta blocker, to pick up the ARNI as our preferred choice. Obviously, the patient cannot tolerate ARNI or cannot afford it, we can use ACE inhibitors or ARBs. The mineralocorticoid antagonist is important to use, and we're going to talk about the SGLT2 inhibitors and the vasodilators and the obviously what else can we do. Important that we want to get the patient on the medication, and we want to up titrate this to the maximum tolerated dose because we know the higher the patient gets, the better the response. This is our current armamentarium for heart failure stage C, so the patient becomes symptomatic. What is the evidence that patient should be starting or ARNI, Entresto, plus beta blocker? What are the two beta blockers that are appropriate? Carvedilol and metoprolol succinate, long-acting metoprolol. Mineralocorticoid antagonist, you can pick up between aldactone or eplerenone and SGLT2 inhibitor. Important the patient coming to the hospital, we want to diurese the patient, decongest, you use diuretic. Important when you have patients on maximum medical therapy, if the patient is African American, because we know they have energy oxide deficiency, those patients also do better. The rehab trial show that they do better with hydralazine isosorbate added to the GDMT, not instead of GDMT. Okay? In patients that you have all the GDMT on board, but if the heart rate continues to be up 70, patients that are symptomatic still coming to the hospital, ivabradine has shown a significant benefit. And in patients that have high risk for rehospitalization, now we have a new kid on the block that is the Verosigual. Important with Entresto, and I didn't put the trial because I know people have been talking about trials. So we had the Paradigm trial that basically shows a significant benefit of Entresto. We know that at maximal tolerated dose, the patient do better. Important to do is that you can start with the low dose and tolerate titrate. There are 3 doses, 24, 26 is number 1 dose, 49, 51 second dose, and the third dose is 97, 103. If you are transition somebody from an IRB, you can go straight to the Entresto. If you are switching somebody from ACE inhibitor into Entresto, you actually have to stop the ACE inhibitor for 36 hours before adding Entresto because of the risk of angioedema. Okay. In severe kidney impairment, you have to decrease the dose. In moderate hepatic impairment, decrease the dose. So it's very important. And the medication can be started the medication can be started before the patient in the hospital, or as you see the patient in the clinic. So it's approved for heart failure as soon as the patient is stabilized before they leave the hospital with the Pioneer trial, and approved in patient with chronic heart failure. SGLT2 inhibitor, important case on the blog. We have a nice review of the cardiac and renal mechanism of ACE inhibitors. We know that SGLT2 inhibitors basically is an inhibition of the SGLT2 receptor that is found primarily in the kidneys. What this do is when you inhibit the absorption of glucose and the level of the kidney, so you allow glucose to come out. So it's like when glucose come out, you actually reabsorb sodium. You have anosmotic diuresis. So we know that that will help to glucosuria and natriuresis, but at the same time diminish the plasma glucose, diminish body weight, diminish blood pressure, diminish uric acid, and improve glomerular hyperfiltration. So it's very important. But we now know that it's not only the renal actions of the SGLT2 inhibition, but also there is mechanisms at the level of the heart that are improving. We know that by MRI, we have shown data that when you add SGLT2 inhibitors, you decrease LV dilatation, LV mass, you increase the ketone, and you made the myocyte to use more free fatty acids that are better energetic molecular for the myocyte than glucose. So because you're getting rid of the glucose, you increase the use of free fatty acid that is very molecular for the myocyte, more effective. Okay, and you decrease BNP, you decrease fibrosis. We know that at the level of the kidney, there is a significant decrease in the fibrosis. There are more filtration. There is significant decrease in inflammation. So we know that it's a beneficial effect at the level of the kidney and at the level of the heart. We have multiple trials, and I can go on and on. We had the DAPA heart failure trial and the Emperor Reduce trial that they both show the significant benefit of using SGLT2 inhibitor. So DAPA uses Farxiga or dapagliflozin, and Emperor Reduce uses Jardiance or empagliflozin. They both show significant mortality benefit in heart failure trials in patients with diabetes and without diabetes, patients with heart failure. Initially, this medication was created to treat diabetes, but obviously the benefit was seen in people with heart failure. So the trial with heart failure, the Emperor Reduce, the DAPA heart failure, the Emperor Preserve, and the delivery that were done with the same compound in patients with mid-range ejection fraction and precise ejection fraction also show significant benefit in patients independent of the fact that the patient has diabetes or not. Then, so those trials show that. Then we had the SOLIS trial that basically is looking at sotagliflozin. Sotagliflozin is the only compound of this family that is the combination of two things, SGLT2 and SGLT1 inhibitor. So the sotagliflozin really is the combination of the. What is that? SGLT2 is mainly found in the kidney. SGLT1 is mainly in the intestine, a little bit of the kidney, and also at the heart level and at the brain. So SGLT1 inhibits the absorption of glucose in the intestine. Same thing, you're basically gonna poop some of the glucose, so you also decrease the glucose. So it's a little more potent because it's affecting both of the receptors. it shows exactly the same thing that the empagliflozin and the dapagliflozin show, that this molecule decrease mortality, decrease urgent visit, decrease hospitalization, and in conclusion, independent of these patients, the SOLIS trial was done in patients with diabetes with worsening heart failure. So this trial, almost 46% of the patients that were put in sotagliflozin, the sotagliflozin was started in the hospital. At this time of the trial, we already knew the effects of AGLT2 inhibition, but we haven't proved that in patients that were hospitalized. So this is the trial that showed that in patients with worsening heart failure, the initiation of sotagliflozin actually improved cardiovascular mortality and heart failure hospitalization. So, and also now we also have the DAPA and the empagliflozin trials for worsening heart failure. So we know that this trial put this molecular in the picture. Also, for sotagliflozin, there is a trial. This trial was used obviously because all the patients in this trial had diabetes. So we were looking also at the decrease in 3 points of MACE, like non-fatal MI, non-fatal stroke, and cardiovascular death was the initial data collected, and there was a significant 21% reduction on top of medical therapy, with a 25% reduction in events in these patients. So really, this put that in the market. In summary, for all 3 classes of these drugs, the main side effects are going to be UTIs. So it's important to explain the patient that because he's going to be peeing urine, maybe a little increase, but if you look at the data, it's not significant increase. Some person can cause diarrhea. And another thing for the UTI is very important to remember in patients with UTI, sometimes, especially in elderly women, they can have concomitant bacterial infection with mycotic infection. So sometimes you have to treat both. So that the only thing that was significantly maybe more in patients with this medication is the general mycotic infections, because over European sugar is very important to have good hygiene. And now with the sort of with the SGLT2 inhibitors continue to increase, because now we have data in how this medication not only work in patients with diabetes and heart failure, not only in patients with heart failure, independent of the ejection fraction, because we know that delivery and imperopressor have percent ejection fraction, but also we had data before that in patients that are at risk of developing heart failure and patients with chronic kidney disease. There is important prevention for heart failure. So really, these medications, SGLT2 inhibitors, are now indicated in patients with preclinical heart failure, in chronic kidney disease, and people with diabetes to decrease the risk of heart failure and the chronic kidney disease. Because we know that this is the effects of these medications are not only at the level of the diabetes, because we have seen that there are actually significant statistical benefit in people with diabetes in decreased hospitalization. We know it has significant benefit in people with heart failure, independent of the ejection fraction and independent of the fact that they have or don't have diabetes, and also significant benefit in people with chronic kidney disease, the same thing, independent if they have heart failure, independent if they have diabetes. So this, I love this graphic because basically tell you that these medications really are acting at all the levels in these 3 different conditions. So now it's indicated for these 3 patients. How you use it, when you have a patient in stage 8, it's very important to first of all, optimal blood pressure control, treat the patient, you get a BNP to see what the risk factor is. There are multiple validated multivariable scores that you can use, and more for prognosis. Stage B, you have to be a little stronger. You have to make sure that the patient have what he needs, ACE inhibitor, ARB, beta blocker, no? If the patient is an ICD, because the EF is low, even before it becomes symptomatic with heart failure, is very important, especially 40 days post-MI, and increase the survival in these patients. In patients with non-ischemic cardiomyopathy, genetic counseling and testing is a 2A indication. You offer it to patients, hopefully, in many conditions, we don't know that much, but there are conditions that we actually can know. Once you start the medication on these patients, you start the medications, you titrate the medication to the maximum tolerated dose, you monitor the kidney function, the electrolytes, and you see what can you add. Talk about this. Let's talk about this after. So you have the patient already now in stage C, symptomatic heart failure with reduced ejection fraction. We had that on all the medication. Then you have to see, I want to get my patient over stage C with a better ejection fraction, and if you put all the medication as fast as possible, you may get them on remission. What if the patient doesn't get on remission, or the patient more symptomatic? We know African American patients benefit of hydroxyl nitrates. The data is very clear, so we can add those to them. We also know that person with class 1 to 3 heart failure, less than 35%, ICD, very significant improvement in survival, independent if it's ischemic or non-ischemic. And we also know that some person benefit from CRT. I'm going to talk about that. And then we talk about other therapies. Our patients, if patient has symptomatic refractory, despite everything I'm doing, if he has symptoms, is hypotensive, kidney function is worsening, then we have to start thinking that this patient needs palliative care because they don't have options. This patient needs to be referred for transplantation, or this patient needs to be referred for mechanical support. Once you optimize the patient, additional therapy. So we're going to talk about ivabradine, verociguat, digoxin, pofan, and potassium. So ivabradine, so verociguat, the Victoria trial definitely show verociguat is basically a direct stimulator of the soluble guanylyl cyclase that basically is a vasodilator. So verociguat is similar to riociguat, but different. Same company, but this is specifically for heart failure. We know that this increase the guanylyl cyclase, increase the cyclic GMP, and is beneficial for patients. This trial was done in patients with after stabilization from the hospital, that were still symptomatic, a little more symptomatic, lower ejection fraction, and it showed that definitely this medication decrease hospitalization and decrease the composite endpoint or hospitalization and cardiovascular events. So we do use it in patients as an add-on of maximum medical therapy, and in certain persons it's very beneficial and it's available, but also it goes from 2.5 milligrams to 10 milligrams, and patients tolerate the medication very well in this still symptomatic patient. Ivabradine in the SHIFT trial, you show that they actually, apologies because it's SHIFT trial, not SHIFT. Okay, so basically, most in patients that have persistent tachycardia, heart rate more than 70, or patients that don't tolerate beta blockers and MAC dose, there is a significant benefit in adding corlanol in this patient with decreasing in the composite endpoint better than placebo. Not a lot of the patients tolerate this. Has not been used as much and definitely decrease in events. Digoxin, oh my God, we had this for a long time. We know that the serum digoxin in the DISH trial show increased mortality, but we know that in certain patients, for rate control, especially in people with AFib, certain person with RP dysfunction, this has been beneficial. So this can be used in this patient as an add-on therapy, depending on the indication of the patient. Another thing that is important to mention today is the potassium binder. There are several potassium binders. They have the sodium polycystidine sulfate, the sodium zirconium cyclosilate, cannot remember the names, or the patiromer. This is basically what we have been found is in patients, we know that in patients with heart failure, they do better in maximum medical therapy. We know that when we discontinue medical therapy or we withhold therapy because of these things, we increase mortality and we increase readmission rate. So we need to find ways that we actually can keep people in medical therapy. I treat a large non-English speaking population and a large Hispanic population that they like to use his bananas and plantains and a lot of potassium, so it's very important for this. So I had to add that. AICD, multiple trials in patients with AICD and CRT trials. I will say the ICD definitely is a significant benefit. We don't know much about current medical therapy, and there is a current trial evaluating this, but we do know that CRT is very beneficial in patients with left ventricular abundant branch block with an QRS more than 150. They will benefit class 1 recommendation. We know class 2 recommendation is a non-left bundle, but the QRS is more than 150, or is a left bundle between 120 and 149, patient symptomatic. Okay, so it's very important. And then over you have other options as RB patient. If you have AFib and the RB patient is frequently, you're going to create the synchrony. Maybe you're better to pull CRT. Okay, so it's very important that we remember the recommendation. Other therapies. So surgical revascularization. If the patient is somebody that you think have viable myocardium and a possibility to improve, obviously by all means indicated. We do know that severe EMR, that we're going to talk about that, there's a possibility, and monitor to improve hemodynamic control of patients. We know that secondary MR, because there is left ventricular dilatation in the patient that is disproportionate, so that patient that have an ejection fraction between 20 to 15, with the left ventricular and systolic dimension less than 70 and PA systolic pressure less than 70. So a patient doesn't have pulmonary hypertension. We know that the TEER, like the transcatheter valve approach, can help this patient either as a therapy or as a bridge to something. We do know that when the person has severe symptoms in optimal medical therapy and GURIEF, you should have mitral valve surgery and it's contraindicated. And you should consider mitral valve surgery even if the ejection fraction is lower, but over you need a hard thing to be able to decide or if the patient is going for coverage and have mitral rehabilitation, you should probably consider to have mitral valve surgery. Unfortunately, the omecamtiv bill was an oral myosin activator, and unfortunately, even though it used a cohort of patients that were with advanced heart failure with lower ejection fraction, and actually showed that in patients with advanced heart failure, very low ejection fraction, less than 28, more than class 3 heart failure, there was some reduction in heart failure hospitalization. Unfortunately, it did not achieve indication, and it's definitely not in the guidelines. I hope something is coming in the future. So for now, I can tell you that the therapy today includes these, I say 4 to 5 pillars. You have to have a patient on neprilysin inhibition. If the patient cannot tolerate that, you can use an ACE inhibitor or an IRB. You can use a beta blocker, metoclopramide or carvedilol, MRA. I showed you MRA, and SGLT inhibitor is the pillar of therapy in this patient. These are all the trials to compare and the latest trial, so it's very important that we remember that. This trial is strong heart failure, the trial that put into our view that patients needs to be optimized as fast as possible, and it can be done multiple ways. And when patients have rapid titration, they have rapid decreased mortality, improved quality of life, and better outcomes. Sometimes it's challenging, but it's definitely something that we can do. Then we have the patient that have decompensated pump failure. That patient that despite everything that we're doing, he's getting sicker. So how we recognize that patient? So overly, we had the state of the shock that I'm not going to go into because there's a whole lecture. It's important when a patient comes to the hospital to determine the patient is in shock and if he's getting worse in shock. But we know that when patients are already like failing on anothrobes, recurrent hospitalization for anothrobes, this is a patient that is failing, and that's only a patient that we have to consider to refer for mechanical support or transplant. Warning signs, patients that are repeated hospitalization. Every time the person comes to the hospital, the mortality increase. Patients that have persistent hyponatremia. Very ominous sign you have hyponatremia of advanced heart failure. Patients that have intolerance to the ACE inhibitors, ARBs, or ARNIs. GFR is reducing. You have to actually stop the medication because he doesn't feel well. Very important. People that require very high dose of diuretics. One thing that is good about optimal medical therapy is that you actually have to back off in the diuretics. But that person that you have to keep the person in torsemide 100 times a day is a person that is not doing well. People that get worsening kidney function every time they come to the hospital, we know that the mortality increase. Person with persistent elevated proBNP or BNP is the person at higher risk of advanced heart failure, or person that really that require anothrobes every time they come into the hospital. Patients that have multiple ICD shocks is definitely a significant warning sign. These are the American Heart Association, European Society of Cardiology, and Heart Failure Society, looking at a combination of factors that predict when somebody have advanced heart failure. Word of caution, be careful in women. Sometimes women, because they're smaller, they are petite, they can camouflage the symptoms very easily. We do a cardiopulmonary stress test. It's an exercise test, very simple. We look at the peak VO2 less than 14, significant mortality, and person we should prepare for advanced therapies with the VO2 predicted less than 50% and a PE of VCOLU more than 35%. We do predictor modeling. Now with AI, you can just plug Seattle Heart Failure model, you have magic, you have many things, and you can predict what is the chance of survival, what is the freedom for an event. I personally do a lot of these things in my office when I'm trying to talk to patients, when I'm talking about advanced heart failure therapies. You can look at this, you can go into the website, you can download it in your phone, and you can calculate it very easy. A lot of them are old, and a lot of them are not done with current medical therapy, so I will give you more caution on that. And then you have to decide. Hopefully, we will like all these persons to get to heart transplant, but it's very difficult because sometimes you have to see, well, the person is a candidate. Does he have another systemic illness that may not be a candidate for heart transplant, or maybe not for heart transplant alone, that he needs a heart and a liver, or a heart and a lung, or a heart and a kidney? Substance abuse, mental illness, irreversible pulmonary hypertension, or obesity are definitely contraindications for transplant, so that person is not a candidate for transplant, but also mechanical ventricular support could be possible for these patients. We know that the number of transplants are increasing. We have a new allocation system policy, so we basically are getting people transplanted at the higher level of disease, so people that are in ECMO who have life-threatening arrhythmias are going to get transplanted faster. Status 2 are people in ventricular devices, complications for devices, and that's how it counts who get transplanted first and who get transplanted later. Or we have mechanical support, either as a bridge to transplantation or as a destination therapy, because we know that patients in medical therapy or in an autologous infusion, short term or long term, have worse survival. So we had this mechanical support. Currently, we only have the HeartMate 3, because it's a smaller pump. You look at the pump, it's definitely a smaller pump. What is the good, the bad, and the ugly? The good is quality of life and recovery, especially in women, a significant improvement in recovery, because women tend to have non-ischemic cardiomyopathy, pericardial cardiomyopathy. So that's the good about the mechanical support. The bad is obviously person has to be anticoagulated, and it is very, very high incidence of thrombus and stroke, and the ugly infections. Obviously, all this can happen. We had with the new pump, the Momentum 3 trial has shown that definitely you can live without the pump and you can do very well for many years. So we know we had done overall survival with the HeartMate 3 is significant to 79%, and the 5-year follow-up study really continued to show that there is significant improvement in survival in patients with HeartMate with the left ventricular device support, up to 58% free of any event, free of mortality, less bleeding complication, far less bleeding from any kind, GI bleed, of pump thrombosis. That was the case. Now, because of this, now we're looking into trials to determine if we can actually use NOACs or we can actually decrease the INR target. So now it's in the guidelines. In selected patients we have HFrEF with persistent class 4 heart failure, patients should be considered for mechanical support. Obviously, transplant no is in the guidelines as a choices. When you look at the survival of patients at 5 years, it's about 70% for every patient. Sometimes even better survival than high-risk transplant patients. So we have to remember that. Sometimes patients are too risk for transplant. Triggers to refer a patient, I talked to you guys already. Worsening heart failure, persistent hypotension, that you have to decrease the medication because of hypotension. Class 3 to 4 heart failure, need to use inotropes. Remote monitor, we know that before we have patients with symptoms, there are increased filling pressures, increased thoracic impedance, and we want to get activated before that. So basically, with the progression of heart failure, we know that the cardiac function disease, the pressures continue to elevate. This device is very small device, like a quarter, and you can monitor the person every day. The Champion trial really showed that when you monitor patients and follow these patients, there is a significant decreased hospitalization and improved quality of life. This is the pillow, the patient lying in the pillow, send the recording, our nurse will monitor it, and the patient can be told if he needs to quit diuretics. And to finish here, mitral regurgitation. We know now that there are different kinds of mitral regurgitation, and we know now that people can become very symptomatic. We know that there are primary degenerative mitral regurgitation or functional mitral MR. We know it really depends on the mitral clap, but we know that even in patients that don't have candidate for surgery, mitral clap have been a system that have been improved in patient survival. And when you look at the data between men and women, because I do a lot of gender-based difference, there is significant improvement in all the symptomatic things in patients with MR treated with clip. We had the co-op trial that really showed superiority and mitral clip by GDMT. I'm not going to go into this because I don't have too much time. But basically, when you compare the MR side, that was the co-op trial, the mitral trial, it showed that this percutaneous approach was good. But there were a couple of differences. Important to remember in the co-op trial that the patient needed to be optimized before going to the therapy. In the mitral part, the patient didn't need to be optimized. So one thing that we learned is that the patient that benefit in this case of the clip is the patient that have the patient in the co-op, patient that was disproportional MR. So the MR was the issue, not the ventricle dilated. So we know that patient that have a ventricle that is less than 7 centimeters do better. For here. So basically, we know that the patient with the EF more than 20 and the left ventricular end systolic dimension less than 70, definitely the mitral clip is useful. Okay? The metaclip is futile if the person has low EF, and mild to moderate MR, because that's proportional, that's the ventricular problem. We still have to think about the severe MR with very low ejection fraction. It's very difficult. One thing that we published and we presented is the importance of optimized patients, because sometimes you can actually get patients MR better without nothing. 45% improvement in MR. So we can get people with control of the MR if they actually get optimized. But you definitely have to have a team of people, cardiovascular imaging, heart failure cardiologist, cardiothoracic surgeon, and structural intervention to be able to design. There is tons of device therapy coming independent of ICD, and I'm sure guys gonna get an ICD. There is a varicose therapy for improvement symptoms and the cardiac contractility modulation for improved symptoms. Those therapies are focused in autonomic regulation, sympathetic nervous system. Parasympathetic therapy is a chaotic stimulator that you can put at the level of the carotid baroreceptor, that you can decrease the sympathetic tone and has shown to improve quality of life, to improve exercise capacity, and New York Heart Association class, as comparable to any of the CRT trials. So in patients that are not candidates for CRT or are not CRT responders that have symptomatic heart failure, persistent elevated BNP, this is an option for treatment, is currently out in the market. Cardiac contractility modulation have been done, is a bigger device that can be implanted at the level of the right ventricle to increase contractility of the heart, has shown in preliminary studies to increase contractility, to improve heart failure symptoms, and is available in the market. Currently, we're doing a trial looking at the application of this device plus an ICD lead to be able to improve contractility. Obviously, we're talking about younger patients and people that you think you can improve. So really, you have to have a disease management program. It's very important that you have, for patients with heart failure, you need to get all the GDMT on them. You need to educate the patient and the family about food, when to take the medication. Simple thing about when to take the diuretic. Sometimes patients don't take the diuretic because they don't want to pee all day. But you may tell them, take it in the morning if you're home in the morning, or take it at night when you are home. It's important that they have access, or you can monitor early clinical deterioration because you can act. And it's important to diagnose what the patient got decompensated, because you need to control that, because the patient is going to continue coming to the hospital. Very important that the cardiologist or the person that evaluates the patient communicate. Many times the patient leaves the hospital from the ER, goes to the primary care doctor, the primary care doctor have no clue what happened. So it's important that there's a lot of communication between the different practitioners. So, and then obviously, as I say, important to refer the patient for advanced heart failure therapies if he needed. I'm happy to talk about advanced heart failure therapies again and be more deep in another lecture. My take-home points is that heart failure is a rapid growing epidemic with the high morbidity and mortality. There are not stable heart failure patients. If you look at the clinical trials, especially you look at Paragon, the water trial with Entresto, you look at persons with class 2 to 3 heart failure, those patients dying during the trial. The majority of mortality was in class 2 to 3 heart failure because there are no stable patients. There is a lot of comorbidities, a lot of issues. It's important to get rapid optimization of medical therapy is the key. You can get patients on remission if you actually work with them. Important to recognize signs of advanced heart failure. Important to monitor patients, to create access to patients, to maintain euvolemia. Consider options in severe MR. Don't let the severe MR get worse because they may not be able to work. And we also have options for severe TR if that's the case. Device therapies, we have multiple devices in the market. There is a big revolution this year with the devices. Early referrals to advanced therapies. If you think that the patient is healing that way, the earlier we can get the patient evaluated, the better, because then we can optimize and we can get a better candidate for advanced heart failure therapies. One of our biggest problems in transplant is that we get patients too late, too sick. So sometimes they actually die on the waiting list. And disease management programs are very important because we really need to talk about our show because we need multiple people taking care of these patients. So this is several of the person with the LVAD and transplant. And thank you so much for having me here.